And thank you to Decathlon and Ace Adventure for organizing this talk. Is the sound level okay for people at the back? Good? All right. If it's too loud, maybe you can just put on earplugs. So thank you for coming out during this Chinese New Year period for getting some updates on high altitude stuff. That's a pretty generic slide for most talks in North America. How many of you have been to high altitude places? Great, so a good number. And some of these slides that I show you will have been places that you have been to, and maybe some places that you hope to go to. I intend for this talk to be as interactive as you want to be. At any time when I'm talking about something and you want to ask a question, make a comment, please feel free to raise your hand and contribute to that, okay? So, been there, any one of you? Recognize that? That's in Tibet. Okay, what about this one? Machu Picchu! Okay, I got no prize lah. This one, maybe those who are ski buffs, that's in Colorado. And what about that one? You see it on posters. That's Mount Everest. Okay, so they're all considered high altitude places, and they vary between 2,500 meters to, right up to Everest, which is 8,000 over meters. So, and there are lots of places in the world which are considered high altitude, okay? Too loud? Yeah. Let me just... Maybe I can get the Decathlon guy. I'll stand further away from the speaker. I think that's what they prefer. That's okay. I'll stay away from the speaker. So, a lot of places in the world that we visit, either as tourists or as trekkers and mountaineers, can be considered high altitude. And generally speaking, anything that's more than 2,500 meters is the level where our body tends to tell us that this is different than being in Singapore, which is pretty much close to sea level. And it's not just going up to the Everest Track and Kilimanjaro, which is like 4,000 or 5,000 meters, that people can get into trouble. And this is a news clipping from just 2 years ago. Boy Scouts going on a weekend hike, and he got into trouble, but they didn't recognize that he had high altitude related medical condition, because they thought, oh, we're just hiking in the mountains in Utah, which actually can be as high as Kinabalu, and eventually he died. But that's very sad when you don't recognize, or people who bring groups out don't recognize the symptoms of conditions that can happen at high altitude. So that's one of the purposes of our talk today, is to introduce you to and familiarize you with some of the things that can happen when you go to high altitude. So if you look at this slide here, okay, I don't think pointers work very well on TV screens. Anyway, Bukit Timah Hill, Singapore, is pretty close to sea level. This is where I live in Roslyn, which is just a little bit higher, probably the altitude of Cameron Highlands, not high at all. Kinabalu is significantly high. You can definitely feel the effects of Kinabalu. I think any of you who have been there will find that, okay, this is not quite like walking on Bukit Timah Hill. Everest is way up there. So you can see that as you go from sea level to very high up, the amount of oxygen that's available to the body is reduced. And this is one of the basic reasons why our body behaves differently at high altitude. With time, greater time spent at altitude, going up slowly, the body adapts. But if you bring a person from sea level at Singapore and drop him even at the Everest base camp, they will be in severe distress. So when you go to at high altitude, there are two main issues that we have to talk about. One is the actual high altitude, which will have its own effects related to the reduced amount of oxygen available to the human body, as well as certain environmental injuries which are related to being at that level. Usually we think about very cold, because high altitude places generally are cold. And the other thing is, most high altitude places are in remote locations. It's true that, in places like Switzerland or whatever, you can take a cable car right up to several thousand meters. But when you go trekking in Everest region or Nepal or Africa, those places are remote enough for you to need to be somewhat self-reliant. So I'm just going to talk about high altitude. Now, when we talk about altitude illness, the risk factors are dependent on the absolute altitude. The higher you go, the greater the risk, okay? The speed of ascent, if you take your time to slowly get up to 3,000, 4,000 meters, you have the luxury of a slow itinerary, and if you have a good travel or trekking company that has a sensible ascent profile, most people will get to their objectives safely and come back safely. People who don't acclimatize so well will have more trouble than others. And people acclimatize at different rates. It doesn't matter whether you're old or young. Age is not such a factor in acclimatization. It's quite genetic. Being physically fit will help you with the rigors of carrying a pack, but it may not necessarily help you to acclimatize faster. And that's an individual predisposition. So when we talk about the medical problems of high altitude, it's a wide spectrum of things. We often hear people talking about AMS, or acute mountain sickness, okay? And that's very common. I think anybody who has gone to high altitude will have experienced to a greater or lesser extent of the feeling of being tired, not sleeping so well, your appetite not so good when you first arrive. The other extreme would be things like HACE or HAPE. HACE is high altitude cerebral edema, and HAPE is high altitude pulmonary edema, both of which are at the extreme end, which, if you recognize it, can lead to death. And these are conditions we want to recognize very early, get the person down to a lower altitude, get help, and get them evacuated so that they will make a recovery. So let's talk about AMS. How many have felt the symptoms of AMS? Okay, so practically everybody who has been to high altitude has. And the onset is not immediate. When you step off the plane, you don't suddenly feel, I don't think I want to go on this holiday anymore, I go home. Usually you go off the plane, it's fine, and then a day or two, usually about 24 hours, 36 hours later, you start to feel a bit lousy. And you think, haven't slept very well, the food here not very good, the hotel bed not very hard, and therefore, I don't feel so good. So the symptoms are very vague. You can have a headache, your appetite not so great, definitely breathlessness on exertion, or just feeling less perky, because your body is kind of deprived of oxygen. Those are symptoms. And this can be anything. You can just be tired from jet lag. So you have to be very aware of these symptoms when you're at altitude. And quite often we say, if you're not feeling so good at altitude, most of the time you can attribute it to altitude. Now, how then do you make a diagnosis of altitude sickness when it's so non-specific? Well, there are several things The first is something called the Lake Louise score. And I will be sharing with you the score in just the next slide. And because most of us will travel with a phone, who travels without a phone? Nobody. Okay, so most people will have a phone and there's a phone app. I haven't used the phone app myself, but I believe that these apps will improve in time as to the usability and accuracy of helping people to make a diagnosis of altitude sickness. So, and again, if in doubt, call it altitude sickness. So this is the Lake Louise score. The Lake Louise score was originally described way back in 1991 by a group of physicians who looked at the symptoms of people who travel at high altitude. And those who anybody has seen or heard of the Lake Louise score in the past? I know the ACE Adventure people have, and yes, ma'am, you have. So in 2018, which is just last year, they revised the score and took out one category of symptoms. So currently, they look at headache, gastrointestinal symptoms, fatigue and weakness, and dizziness or lightheadedness. In the past, they had one more category of how well did you sleep. So they found that sleep quality at altitude is so variable that they've taken it out altogether and just looked at these four. Now, each time they look at one symptom like headache, you can categorize it to 0, 1, 2, or 3, depending on how severe it is. So from no headache to severe headache, 0 to 3 points. Gastrointestinal symptoms. No problem with your appetite, eating so much food that your track kitchen say, can you leave some food for the rest of the people? To severe nausea and vomiting, don't want to eat anything, can't keep any food down. Fatigue and weakness, 0 means full of energy, not tired at all. To severe fatigue, you don't even want to get out of bed. And dizziness and lightheadedness, when 0 is nothing and 3 is so dizzy that you can't even walk properly. So if you go, this is just to summarize, 4 symptoms, severity 0 to 3, and if you add up the score, a total score of 3 to 5 is mild AMS. Anything 6 or more is severe AMS. And using the score of whether it's mild or severe will help you to make a decision whether to stay and rest at that whatever altitude that you're at, or to say, okay, maybe I need to take some medication, or maybe I need to go down a little bit lower so that my body has a chance to recover from the altitude. So if you do diagnose that, okay, you have an altitude-related problem like AMS, what can you do? The simplest is to rest at the same elevation if you have the opportunity. And if you feel really unwell and the score is such that it's severe, you may want to actually go lower, okay, descend. Some people may choose to take medication, and one of the commonest medication that has been prescribed for prevention and treatment of altitude sickness is a medication called Diamox or acetazolamide. There are other medications that I will touch on, I'll give you the name on, but I won't go into the actual drug doses, because really I think that would be something that you should get prescriptions from your travel clinic, and this general forum is not a place for it. If it's severe, oxygen or something called a hyperbaric bag can help people get over those symptoms, because the basic problem is a lack of oxygen to the body. So let's talk a little bit about Diamox. Diamox is a medication that has been around for 20, 30, 40 years, and it has been shown to be very effective, and taken in a dose of 125 milligrams twice a day is about as much as you need. Sometimes in Asians, we are a little bit smaller. Sometimes we can even take half that, those 62.5 milligrams twice a day can be sufficient for some of us who are not as big as some of the Angmos. So, for example, starting the day before ascent. So, how many of you have been to the Everest region or going on an Everest trek? Okay. So, for those in that context, we often fly people from Kathmandu to Lukla, correct? So, if you were going to take a medication like acetazolamide, you would take it the day before you fly up to Lukla and continue taking that until the usual prescription is to take it until you reach your maximum altitude, whether that is Kalapata or Everest Base Camp. Now, some people will just take it until they feel that they're well acclimatized enough and you can stop. That's fine. You're not going to suddenly fall sick from altitude illness just because you stop the Diamox. And it's something that you can start again without ill effect. Okay. Once you start losing altitude, once you start descending, you can stop that drug. So that's the usual way it's prescribed. Now, acetazolamide or Diamox is a sulfur-based drug. So some people have concerns if they are known to have allergies to sulfur. But from the medical point of view and the pharmacological point of view, it is a slightly different group of sulfur-based drugs as sulfur antibiotics. So people have taken it without too much ill effect, but again, you should consult your own family physician because they would know you better in terms of your drug reaction. But these are generalities. The main side effects that you need to be aware of if you take a drug like Diamox is diuresis is a fancy word for you have to go to the toilet a lot. It makes you pee a lot, okay, which is kind of inconvenient, especially if you're trekking out in the place without toilet, in an open place, without even a tree or a shrub to hide behind. Maybe you can bring an umbrella and hide behind the umbrella. But, you know, the problem with diuresis is you want to make sure that you drink enough water to compensate for the extra amount of pee that you produce. And also, because you're taking it twice a day, you don't want to take it just when you get into bed. You're nice and comfortable in your sleeping bag, and you take the Diamox, then 1 hour later, when you finally become warm, you have to go to the toilet. You know, so take it when you get into camp, like 4 or 5 o'clock, rehydrate, take the Diamox, and then you can pee all that out before you actually go to bed. The other thing which is annoying but harmless is your fingers and toes may tingle, kind of like pins and needles. Quite harmless, but could be quite startling, because sometimes even your backside tingles when you get up from squatting on the toilet. So, yeah. Let's go on to something a little bit more severe than AMS. High altitude pulmonary edema. I don't think that most of you would have seen it. I hope none of you would ever have an opportunity, but high altitude pulmonary edema, or HAPE, is responsible for the majority of high altitude deaths. Okay, it can progress very rapidly and can be fatal within a few hours, so it's important to recognize it either in yourselves or in a fellow trek member or expedition member. Okay, so the risk factors of a person developing HAPE would be a very rapid ascent, so going up to high altitude without the opportunity for the body to acclimatize. If they go up rapidly, do a lot of vigorous exercise, increase the blood pressure within the lungs, within the pulmonary tree, that means the blood vessels that supply blood to the lungs. And if they are having a concurrent or simultaneous respiratory infection, or have had a respiratory infection just before going on to altitude, That it makes the lungs a little bit more leaky and more fluid to come out into the air sacs. And once a person has had, some people are more susceptible to high altitude pulmonary edema, and it can reoccur in some of these individuals. So if you're traveling with somebody who has had HAPE before, you might need to be a little bit more vigilant, or they might need to be a little bit more vigilant. So this is just a little cartoon to show what pulmonary edema is. So a nice lung full of air and oxygen is nice and pink. When you have pulmonary edema, the air sacs in the lungs, the alveoli, in which we exchange oxygen and carbon dioxide, is filled with water. So it reduces the amount of oxygen that we can get in from the atmosphere. And because of all this water, the people who have HAPE will be coughing all the time, and sometimes the cough is very wet. And if there's enough water, they might actually be kind of gurgling and bubbling. And if you put your ear to their chest, and sometimes, if you're in the same tent or in the same bunk room as that person, if you just put the ear to the chest, you can hear it gurgling and crackling in the lungs, and that's something that should raise an alarm in your brain. Okay, so how do you diagnose it? How do you know that this person has HAPE? A high index of suspicion. Okay, this person, your trek itinerary is very rapid. You've achieved 3,000 meters or 4,000 meters in 1 or 2 days. You've done a lot of vigorous exercise. That person maybe has a chest bug. Okay, these are risk factors. So what you need to do is look at people at the end of the day of climbing or the end of the day of trekking. Just sit down and just review. Have you been very tired? Have you needed to just, when you walk every 10 steps, you need to stop? That's not at 8,000 meters, but this is at 3,000 meters or so. If everybody else is walking okay, and this person is like, wow, 2 steps and then they're bending over, they're breathing, and they're coughing, then something is wrong. Or they're just tying their boots and they're breathless, just sitting down talking to you, they can't talk in full sentences, that's abnormal. Most people at altitude, if you're otherwise healthy, sure, a bit of exertion, you'll be breathless, but once you sit down and rest, you should be breathing normally and talking normally. If you have one of these finger pulse oximeters, which nowadays are very cheap, you can buy them online for way less than $100, $50 or so. It's reasonably accurate for this kind of purpose. If their heart rate remains high, their saturations are extremely low, and you may want to ask me, or you should ask me, what is extremely low? Okay, I'll go into that. So when you have this pulse oximeter and we look at the amount of oxygen that is in the person's tables for it, and I'll give you an email at the end of the talk, and you're free to email me for more information. Okay, so what do? The usual thing is, if it's severe enough for people to be coughing out blood or coughing out lots of wet sputum, they should go down. Okay, no question about it. They should reduce the physical activity. So if you've diagnosed high altitude pulmonary edema in somebody, they should not be actively walking out. Ideally, they should be carried out, because any form of physical activity will increase the pressure in the blood vessels going to the lung, and this makes it worse. You should keep them warm, because cold makes you shiver, cold makes you vasoconstricted. That means constricts the blood vessels that are in your arms, legs, and again, this makes HAPE worse. If you have oxygen available in a cylinder with your trek guide, they should receive some oxygen, and this reduces the severity of HAPE. If you have had a medication prescribed by your travel clinic for this purpose, you can give it to them in this kind of dose. And again, if you have a hyperbaric bag within your travel group, that may be helpful. But the basic treatment is to bring them lower, even if it means, getting a porter or getting a mule, or I'm not sure about people sitting on a yak, but a mule might be safer, okay? To bring them even 500 meters lower will be helpful. 1,000 meters would be fantastic. Let's go to the other dangerous thing, which is haze. High altitude cerebral edema. So just as pulmonary edema is water collecting in the lungs, cerebral edema is water collecting in the brain. So the brain starts to swell, and that happens again from lack of oxygen to the brain cells. And typically AMS will precede haze. Patients will complain of symptoms of AMS before they actually develop cerebral edema. Typically they will have a severe headache because the brain is so swollen. And typically, again, this is not relieved by simple medications such as Panadol. Quite often they are unsteady on their feet. Ataxia is just a fancy term of being unsteady on the feet. Quite often they have a change in behavior. They may become, unreasonable or aggressive or just confused. They may hallucinate, they may be disoriented, they don't know where they are. And sometimes they just maybe just super sleepy, they don't want to get out of bed. They may be hard to wake up. So if anybody exhibits this sort of symptoms, again, in the context of high altitude, you want to be thinking now, is there something significantly wrong with this person? Does he or she need to go down lower? Okay. Sometimes the ataxia may not be super obvious, especially if they're so tired you can't get them to walk, but there's several things that you can do. You can make them do the test that policemen do when they test you for drunk driving without the breathalyzer. Make them walk, heel to toe, okay? You can make them do finger to nose. Okay, cannot. Okay? And if they can't do that, they have a lack of coordination, which in the context of trekking and climbing, if you have that ataxia, you should not be on the mountain, perhaps. So, what happens if you're on a trek on the mountain and you have a headache? Sometimes it's just a simple headache. Okay, you don't have to be too alarmed. There are differential diagnoses. Okay, it could be just a normal tension headache. Maybe you carry the pack and it's really heavy and your neck muscles are straining. That could be the cause. Sometimes we don't stop to drink enough water and it's actually quite hot on the mountain, and you could just have a dehydration headache. And these two are fairly easy to eliminate as a differential diagnosis. So if they're hot, get them out of the heat, give them some water, rehydrate, and give them a Panadol. And these two should be relieved. Tension headache, if you can get somebody to give you a massage and it goes away, then that's fine. But these two, Panadol and water and massage, don't really help. Okay? David, that's Justin, by the way. Okay, so the management for cerebral edema is pretty much the same. Get them lower. Oxygen, hyperbaric bag, a drug called dexamethasone, which is a steroid drug. Again, this usually is prescribed by the travel clinic in the context of going to a high altitude trek. So when they do prescribe it, they will give you instructions on how to take it. So what is a hyperbaric bag? It's like a big plastic bag, giant bag that is big enough to put a person in. There are different brands, but they all achieve the same purpose. You put a person in the bag, you zip it up, you pressurize it with a foot pump, and you constantly pressurize it by having a fellow trekker or anybody to keep a constant supply of fresh air going in and keeping the pressure higher than whatever is in the surrounding altitude. And once it's fully pressurized, it simulates a descent of usually about 1,000 meters to even 1,500 meters. And that quite often will help to relieve the symptoms of that person. It's a useful standby to have, especially in the situation where for whatever reason you cannot bring that person lower. Maybe the weather is so bad that it's too dangerous to travel. Okay. Now I've just put up this slide just to say that quite often at altitude, many people have disturbed sleep. The quality of sleep is not the same, and there are many reasons for that. Some of it is just purely environmental. You're not used to the bed. It's not comfortable to sleep in a sleeping bag. But a lot of times it has to do with the altitude and how it changes your breathing at night. I won't go too much into that because I want to go a little bit more into altitude sickness. So altitude sickness is not a nice thing to have. It can ruin your holiday or just make it not so fun, or it can be just, purely dangerous. So you want to know, are you at risk of it when you travel? How do you know where you're going or whether your itinerary is going to put you at risk? So there are different risk categories. Low risk would be for somebody who has no history of altitude illness, and sometimes we don't know, right? You have never been to altitude and you're going on a trek. So how do I know? If you're going to a place that's less than 2,800 meters or less than 3,000 meters, it will taking more than 2 days to arrive at that level, and then subsequently, as you ascend on your trek, you don't gain more than 500 meters a day. That's generally low risk. And at every 1,000 meter gain in altitude, you have 1 rest day. That's a nice, relaxed itinerary. What about moderate risk? Okay, anybody who has had a prior history of AMS and going to about 2,500 or 3,000 meters, they're at moderate risk of developing AMS again. Anybody who has never had AMS before but taking a big jump to 3,000 meters, 3,500 meters, or those who are achieving that very rapidly and not having any rest days in between, you don't give your body time to catch up in the acclimatization process. What about high risk? Again, people who have super fast itineraries, and when I say super fast, one of the things that come to mind are some of the very, very short itineraries for people climbing Kilimanjaro. Right now, that probably has the highest AMS occurrence profile in any sort of trek, because it's so easy to get from the bottom to the top. In terms of the stages that you walk, the actual physical distance is not great, but the altitude gain can be very great. So a lot of people do get altitude sickness, and that may just totally ruin the trip or ruin their chances of getting to their objective. So when we talk about achieving acclimatization, there's several ways of doing it. One is one-stage ascent, or intermediate staging, or gradual ascent. And that can work for different types of trip itineraries. Okay? So for example, if we fly from Singapore to Lhasa, just on a purely kind of tourist kind of trip, okay? Singapore is pretty much sea level. Lhasa, when you fly into the airport, actually it's very interesting when you fly into Lhasa airport, because if you have an altimeter and you wear it on the plane, it reads maybe 2,500. Then as you start the plane is descending and your altimeter is rising, because Lhasa airport is like 3,500 meters. That's a big jump in altitude. And a lot of Singaporeans I know will have reported feeling unwell at Lhasa, and some actually do end up in the hospital in Lhasa. So what do? you can take Diamox, or you can, once you get to Lhasa, you make sure that you have at least 2 days of rest. Just gentle walking around, looking at sights and all that before you actually go out and do tourist stuff in even higher altitude places outside Lhasa. Intermediate staging, the most typical one that Singaporeans are familiar with will be trekking in Nepal. Most of the treks are fairly gradual, going to Everest Base Camp or Annapurna Base Camp. We often build in rest days every 3 days or so, every 2 or 3 days. And that fits into the profile of going up to about, flying into Lukla, which is 2008, walking for 2 days, you stay in Namche, you have a rest day in Namche, you do some acclimatization walk, and you come back to sleep in Namche. And then you go up a little bit further and you have another rest day before you actually get to Everest Base Camp. So generally, if you are going to anywhere more than 2,800 or 3,000 meters, you need to have a rest day every 1,000 meter ascent. So which means every 2 or 3 days, you need to have a rest day. Which, when we talk about rest days, it doesn't mean that you sit in the camp and blob. You know, that's a nice day for you to just wander around the locality. You can go a little bit higher and then come back to sleep at your camp at that altitude. We must remember that different people acclimatize at different rates, and that's purely, physiological. It's inbuilt in you. It has nothing to do with, well, you see, like I told you to train when you never train. Okay. And then now like that, you hold back on train. No, they can't help it. Okay. So we try to have, when we plan for a trip, we need to try and build in spare days for the eventuality of people not acclimatizing so quickly. And sometimes you cannot predict. There's this term that you might have heard, climb high and sleep low. And that's to say, when you are training or when you're on a trek, on your rest days, you can go up to another 500 meters higher, but come back to that level so that your body has a chance to recover at that level. But just that little bit of going higher on that rest day exposes your body to even less oxygen and stimulates that process of acclimatization, and then you come back down. The principle is, if you're unwell and the symptoms are you're not getting any better, then you should not be going any higher. And if you get any worse, you should go down. Because, it's very hard to say that, you have to go down, but the mountains will always be there. Okay, make sure that you're there to go and climb. Now this is a picture of a group that I was with quite a while ago, and we're at Everest Base Camp North, and that's right down there, and we're just spending several days staying there, but we're climbing up onto this little hill on the side just to expose our bodies to a bit more altitude before going back down to sleep. Now, some of you have heard of pre-acclimatization. There are lots of gadgets, and some expensive and some not so expensive, that kind of expose you to what we call a hypoxic environment, an environment with reduced oxygen for either a few minutes or a few hours, to try and pre-acclimatize you before you actually physically go to a high altitude travel or trekking destination. So does it work? Is it worth paying all that money? Of course, the people who sell you these things will say that it does work, and studies have shown that generally you need to spend an extended period to really get the benefit of an exposure to high altitude environment. So they have hypoxic tents for people to sleep in, and some people will exercise for hours in a reduced oxygen environment. And that's a facility which is not really available to most of us, but I put it out there to say that people have tested it and it's available to maybe some high performance athletes or people who can pay the money. But most of us, I think, should just concentrate on having sensible itineraries. I did mention that I will talk a little bit about medications for altitude sickness. And acetazolamide or Diamox is the most common. It has been around for many, many years, and it's dependable. Dexamethasone, again, is also a well-timed tested drug. It's usually used for treating cerebral edema. It has been used as a preventative drug, but the word of caution about using dexamethasone as a preventative medication is that if you do stop, there is a greater risk of like a rebound. So we try not to use that. Nifedipine is used mainly as a medication to treat pulmonary edema because it reduces the blood pressure within the pulmonary tree. It's very effective, and these are medications that the travel clinic will routinely prescribe for people going to high altitude, and with the prescription will be instructions on how to take it. Those who go to the Everest region do attend the talk by the Himalayan Rescue Association. They do a lot of good work there, and they do give you good advice for going to altitude. Now, these are some of the things that we've heard people say. Don't use caffeine at altitude, or physical fitness protects you from altitude sickness. You must drink a lot of water, okay? Water is very important. And children cannot bring the altitude because they're more susceptible to altitude illness. That's all rubbish. Okay. You can drink coffee at altitude. And now in Namche Bazaar can have lattes and cappuccinos. True or not? Yeah. Okay, so golden rules. Go up slowly, ascend slowly. If you feel unwell at altitude, usually we would say it's altitude sickness unless proven otherwise. And if you are already symptomatic, don't go higher. Stay at the same altitude until you get better. If you're unwell and deteriorating, go down. And if you know that a person is unwell, don't leave them alone in the tent. If the person is, stumbling, comatose, or very hard to wake up, don't leave them alone and go out and go jalan-jalan, because when you come back, that person may be in dire straits or dead. So, yeah. So these are generally what we call the golden rules. And this is, by the way, a picture taken on Denali. This is looking down at 14,000 camp, and this is the head wall going up. Okay, so this is a little bit of an interval between high altitude stuff and environmental stuff. Okay, all those in the chairs, stand up, stretch first. I cannot be so cruel and say change place with people standing at the back. Okay, all right. Okay, part two. Part two is somewhat shorter, and we're talking about temperature extremes. This is a picture of the Western Cwm. I have not been in the Western Cwm, but Joanne, you have been, and you can tell us whether it's hot or cold.
Very hot.
Yeah. You don't usually associate, being very hot at somewhere which is like 6,000 meters, but with the sun bouncing off the snow, it can be pretty hot. And when the sun disappears, it can be very cold. So you want to be prepared for extremes. So I'm going to talk briefly about sun and heat injuries, which will include dehydration, sunburn, snow blindness. And you know, when we put on sunscreen and stuff, right, we usually put here, here. We never put sunscreen here, right? But you do get sunburn at the bottom of your chin because it bounces up from the snow. Okay, what do these have in common? What's this guy doing? Arc welding. I don't know what he's doing, but he looks like he's in at the sea. And this is a ski place. It's actually Paradise Chair. That's where I live. I don't live at the ski resort, but but close enough to it. So all these three, clear blue sky, you know, water or snow or white background, puts you at risk of what we call snow blindness, which doesn't have to be in the presence of snow. And it's essentially a very general term for solar photokeratitis, which is like a sunburn of the cornea. It's the surface of the eye. It is not a sunburn of the back of the eye, which is the retina. Okay. There's a greater exposure to UV at altitude because there's less atmosphere to filter it. Okay. And we know that native people who live at high altitudes have a earlier age of onset of UV exposure related problems such as cataracts. So it's to our own safety and eye health when we go to altitude to make sure that you have good eye protection. Wear sunglasses that have true UV filtering. Okay, don't go from the market, buy $2 sunglasses. Buy proper sunglasses. Your eyes are worth more than that. And be aware that even on overcast days at altitude and on the sun, on the sea and in the snow, you still have significant UV. So do wear sunglasses. And if you're in a place that is very bright and sunny and on the snow, you may want to have glasses you should have glasses that are wrapped around or have good side shields. Okay, so this actually looks like a donkey with blinkers, but you get the idea. You don't want any light filter sneaking in from the side. And I put this description of glacier glasses here. I'm not sure if the people at the back can see, but I'll just describe it. You want to have glasses that have 100% UV filter. Okay, all the UV is blocked. And the categories of sunglasses, we have category 3 and 4, which are probably suitable for high altitude places and places that have a lot of reflection of sunlight off a wide expanse of snow. So category 3 will filter off anything, leaving only 8 to 18% of the sunlight coming through, so they're pretty dark. Category 4 is even darker. It only allows 3 to 8% of the light to come through. So that's not going to be suitable for cycling around in Singapore, a bit dark. Okay, because regular sunglasses will allow anything between 18 to 43%. So if you're going somewhere there's going to be on a glacier or wide snow field, you may want to look for sunglasses that filter out that much amount of light. So how do you know if somebody has what we call snow blindness or solar photokeratitis? Usually they'll say the eyes are very itchy, they're red, they're gritty. It's as if they have sand under the eyelids. They may be trying to put eye drops to try and get relief and wash out the dirt, but it's not as if they have dirt or sand under the eyelid. It's just the cornea is burnt. It's like sunburn on the corneas. And sometimes there's a lot of tearing, the eyes are red, and even the eyelids can get puffy. So what do you do? If they are wearing, or if you are wearing contact lenses, take the contact lenses out, because if you don't, then it may, and you leave them on, it may become so puffy that you can't remove your lenses. Okay. If you have artificial tears or just normal lubricant eye drops, saline eye drops, use those, because that will help to make it much more comfortable. Pat the eyes, which means that that person can't see out of the eyes, then they will need help. And usually if you pat the eyes overnight, the next day they will be good. The cornea heals very fast. You just need to give it a chance to heal. What you should not do is rub or scratch the eyes, because that could, tear the cornea or scratch the cornea and give rise to scarring. Try to have good eye hygiene. Don't rub it with dirty hands, especially it's hard to have good hand hygiene when you're trekking. And you don't want to introduce an infection in the eye when you're far away from medical help. And don't apply local anesthetic eye drops. Some people have done that, and it makes the eye super comfortable, and then you forget that there's actually an injury to the eye, and you just keep going out in the sun, and it just results in more damage. Okay, what happens if you lose your sunglasses? You can improvise. You can get duct tape. It's essentially anything that would minimize the amount of light getting into the eye. Maybe carry a spare pair of sunglasses. It actually looks better than this in photographs. Okay, so let's go away from the eyes. Let's go to cold injury. When we talk about cold injury, you can think about it in terms of either generalized cold injury, like those of you who are sitting under the aircon draft may feel cold. You cold? Yeah. Are you hypothermic? Yeah. No. Or local injury, such as frostbite. Okay. This is a picture of a road quite near to my house. And when it's super cold, there's ice crystals in the atmosphere, and the sun is not here. The sun is somewhere there, and you have this reflection here, and we call them sun dogs. Don't ask me why dogs, but it's a very pretty phenomenon. Has nothing to do with hypothermia, just to show you it's cold. This is a toe that has first degree or superficial cold injury. It doesn't look like very much, but it doesn't actually turn out very well in this color, but the toe has got a red patch there. So it could be as little as that, and could be quite annoying when it's mild, or could be, very nasty and damaging if it's severe and deep. So when we talk about generalized cold injury, hypothermia is when our body temperature drops below what we normally are at. Usually we're at 37 degrees. That's what our normal body temperature is. Metabolism of food, our general metabolism. When we exercise, we generate heat. When we shiver, again, we generate heat, and that's a natural response. We lose heat by these means: evaporation, convection, conduction, and radiation. So when we are in a hot place, we sweat, and the body tries to get rid of excess heat by sweating, and the sweat evaporates off us, and we feel cool. Sometimes in hot venues, you see this mist. They spray this mist, right? And it's again trying to cool the area down through the principle of evaporation. Convection, we stand in front of a fan, very hot, then you fan yourself, you remove that layer of air that's right next to your body. Conduction, if you sit on a cold metal, if you live in a cold place, you don't want to stand on the toilet because it's very cold. So you lose heat by conduction. And radiation, that's a form of heat loss that we don't actually think about. But if you stand next to, let's say you stand next to an oven, the oven is hotter than you, so it radiates its heat energy to you. But I'm at 37 degrees and I stand next to a cold glass. This glass is actually warm, but let's say it's cold. I'm actually radiating heat energy to the cold glass. So when we think about this means of heat loss, we want to try and prevent heat loss by counteracting all these. So common risk factors for hypothermia: increased heat loss. We don't wear enough clothes when we go to a cold place, and there's a lot of cold wind blowing, increases the wind chill. Decreased heat production, we're lying down, maybe an injured person, they're not moving, they're not producing the heat, or they have some disease that prevents them from producing so much heat. Impaired thermoregulation, maybe they have some brain injury or impaired judgment. People who have cerebral edema, they are confused. Sometimes they want to take off their clothes because they're just totally confused. So even in a cold place, they will lose heat. So increased heat loss, cold exposure, children have a higher surface area, so they will lose heat more. Impaired judgment, usually people who, in the context of altitude sickness, will be people who have cerebral edema. But for us, when we're going around traveling or trekking or hiking or mountaineering in cold places, these are simple things that we can do to reduce our risk of hypothermia. If it's like super windy and we know that the wind is going to come and rip all this nice warm air from around your body, you might want to stay behind a shelter if that's a reasonable thing to do at that point in time. If you're camping and you're sleeping on the snow, you want to make sure that you have a good quality sleeping mat or thermarest or similar kind of inflatable mattress to insulate your body from the ground. Reduce the conduction of heat from your body to the ground. Radiation, the head is a good big surface area to radiate heat. Wear a hat. If your hands, there's a saying, if your hands are cold, wear a hat. And that's not because your hands are on your head, but if you keep yourself warm by reducing heat loss from the head, then you will feel warmer. Evaporation, we know that if you're outside running around and you come into Decathlon with your sweaty clothes, then you feel cold. You get out of sweaty clothes. And I think that's one of the principles of layering when we are hiking or trekking anywhere in cold places. When you start up cold, you have many layers on, but you want to be able to take off layers as you warm up, so that you're not sweating through one thick layer and then suddenly you don't have any dry clothes. So when we talk about hypothermia, technically there are different categories of hypothermia, but for our purposes, we only will talk about the first category, in which the body temperature drops to about 32 degrees Celsius. And this is really the only category that, as lay people, we can manage without any special equipment. So how do we recognize hypothermia? We use the term the umbles as a means of remembering what happens when a person is hypothermic. So they stumble because the muscles are cold. Muscles don't work so well when they're cold. They fumble because the small muscles will get affected by cold more quickly. I'm sure those who have been to a cold place, you try to take out your key, you cannot unlock the car because you take out your coin trying to pay for your ice cream at the ski resort. Who would eat ice cream at the ski resort? Your fingers don't work so well. They mumble because if they get sufficiently hypothermic, the brain process slows down and they can be a little bit confused. Or they could be they may not appear confused, but they could be like, why is this person so grumpy? They're just not themselves, okay? So don't put it down to them being difficult. It could be that they are hypothermic. When the body temperature falls from 37 to 34 degrees, the body starts shivering in an attempt to increase the body heat. So recognize the symptoms and treat them early. Usually it's quite easy. If you see a fellow track member sitting around and they're getting colder, encourage them to do something, engage them in a task, help to set up a tent or whatever, and just the physical activity warms them up. Give them something nice and hot to drink, a warm, sweet drink. Give them calories because that increases metabolism. And if they're so hypothermic that they cannot really help themselves, you may have to wrap them up like a bokmia and apply external heat, like panggang fish like that. Okay, so we always say feed and drive dumb sheep, because when people are cold, they may not be thinking clearly. So you feed them and you direct them to do things, and usually that will generate enough heat to get them back to themselves. A hypothermia wrap is essentially having a vapor barrier, kind of like a thick plastic sheet which is impermeable to water or vapor, and then an insulating sheet such as a sleeping bag. Wrap them inside that, and we all have seen these external heat packs, instant heat. Apply it to places where you have good blood supply. And when we apply heat packs, we don't want to apply it directly on the person, just in case there are burns. You may want to put a layer of cloth, put them inside your gloves or woolly hat, and apply it to the armpit, the groin, and around the neck. So let's move on quickly to frostbite. Frostbite is injury, localized heat injury. So just as, if we touch a hot iron, we get burned. We touch something very cold for a long time, your fingers or your whatever part of the human body which is applied to the cold place will get the equivalent of a burn. So the risk factors for frostbite would be poor circulation. Poor circulation can result from tight gloves, tight boots, rings even, and sometimes when we travel to high altitude, our fingers can get a little bit puffy, so just be aware of that. Exposure to wind and cold obviously will increase your risk. If the person is immobile for whatever reason, say a person who is injured and in a splint, and the splint sometimes has metal surfaces, and you don't take care when you're splinting, that skin may get frostbitten. And there's certain medical conditions which may make the person more susceptible to frostbite. And certainly if a person has had frostbite before, their blood vessels may be more prone to constrict and increase the risk of frostbite, because then the circulation to that part is reduced. So how do we categorize it? You may have heard of first degree, second degree, third degree in the past, but currently now the description is frost nip, superficial or deep. Frost nip is a non-freezing injury, so there's no permanent damage. Usually it just results in severe vasoconstriction. That means the blood supply to that area is reduced a lot for a short period of time, but once it's warmed up, once that part of the body is warmed up, then it becomes normal. First and second degree are quite superficial and involve mainly the skin, and sometimes just the tissue which is under the skin. Deep frostbite will involve blood vessels, bone, and muscle, and that will result in permanent tissue damage. So really you don't want to get to that. Actually, you don't want to get to any of this. But so again, prevention is the best. Hopefully you'll be traveling with people, have a buddy system, especially when it's very cold and you have exposed skin. Make sure that, the nose is very hard to cover. So watch out for your buddy's nose. If it looks white, then you may want to get out of the wind. Make sure that you have warm gloves and socks and proper fitting boots. You want to make sure that your socks are not wet. If they're wet, you should have some spare socks, because if they're wet and sweaty and then you get cold, then you increase the risk of frostbite. Usually early on, the part that is becoming frostbitten and getting very cold may just feel colder and colder, and they say, oh, fingers very painful, very painful. And you recognize that, then take steps to change your gloves or move the fingers and get them warm. Because by the time that, hey, oh, very cold just now, but now my finger's not cold anymore, I can't feel them. Very good, right? No, not very good. It may be a bad thing. So be careful. When it's very cold and you have a high wind, this increases makes it even colder, because it strips away any warm layer of air from your body. This is a recent alert put out in North America. Some of you may have read on the news that there was this polar vortex which came down. The jet stream brings that cold air from the North Pole down across North America, and it became like super cold in places like Chicago, where it was like -50 or something, and it gave rise to, very, very drama kind of warnings for Americans not to even breathe. I'm not sure about that, but but the key thing is that exposed skin can be frostbitten in as little as 5 minutes when it's super cold and super windy. So the National Weather Service has a chart. If you go onto their website, it gives you a relationship between the temperature and the wind speed, and how long an exposed part of the body will get frostbitten. These are in degrees Fahrenheit, which we're not so familiar with, but 0 degrees Celsius with a 20 kilometer per hour wind. 20 kilometers per hour is like if you have a flag on a pole, it's just gently flapping. That sort of breeze, not too windy. At 0 degrees, it's about 25 minutes. But if you have, -30 degrees, frostbite can be onset in 10 minutes. So the windier it is, the colder it is, the greater the risk. And it's nasty. You don't want to get to this sort of stage. So the treatment guidelines are: treat the hypothermia, remove anything that's constricting, watch, jewelry, and then you can take and pawn it off, right, for all the trouble. Remove jewelry or anything that will constrict blood circulation, even earrings, because it's a cold spot. Okay, if you're in a place that is sheltered and you know that that person can be evacuated, the frostbitten part should be rewarmed in warm water, just body temperature, a little bit warmer, 38 degrees. You don't want it to be in super hot water, because you don't want to be cooking the part. Okay. It's very painful. Frostbite is very painful when it gets rewarmed. So simple painkillers like ibuprofen is good. And if it's a deep frostbite, blisters may form when that part of the body, the hand or the foot, is rewarmed. Don't burst the blisters, because if you do, then you increase the chance of infection. Put a clean, dry dressing on after you let the part air dry. Don't rub it vigorously, because the tissue is very, could be easily abraded and torn. Okay, keep the person warm and make sure that their evacuation process is activated. If the person has a frostbitten foot, technically they should not walk on it, because that increases the risk of further damage. I'm going to skip this. Now, there are some useful links. The Wilderness Medical Society has some guidelines on their website which are very useful for lay people as well as medical and paramedical persons. The ISMM or the UIAA on their mountain medicine site has very useful links, not just only for high altitude, but for all aspects of mountain travel. And travel medicine as a whole, in terms of vaccination and stuff, the local travel medicine clinics have good information. There's another good site at the CDC. There is a pocket guide that we have created for the purpose of this talk. I will upload it on Ace Adventures website. It hasn't been uploaded yet, but we will upload it and you can access that. It will be in a form that you can print and download into a foldable pocket information for how to score AMS, what to do with hypothermia and frostbite, how to recognize haze and heat and what to do with it. So this will be the link for that handout. Hopefully we'll put it up within the next couple of weeks. Fingers crossed with the computer. And also, if you have questions, you can email me at this email, which is rosalindmountainmedicine@gmail.com. And with that, I thank you.